Um, so my name is Gene Bowman. I'm faculty in the Department of Neurology, and I head up the clinical trials program and the brain nutrition laboratory at the McCance Center for Brain Health, and I serve as the moderator for these presentations for the McCance seminar series. I have the pleasure today to introduce a new faculty member to the Mass General Brigham institution, Dr. Talia Robinson, who is an instructor in neurology in the Division of Neuropsychology at Brigham and Women's Hospital. She received her BS in psychology and biology from the University of Miami. She completed a PhD in clinical psychology at the University of Georgia, a clinical internship in neuropsychology at the University of California, San Diego School of Medicine, and a postdoctoral fellowship here at Harvard Partners Consortium in clinical neuropsychology at the Brigham. Her clinical interests include aging and dementia. Her research interests are early detection of cognitive change in preclinical Alzheimer's disease, as well as racial disparities in the risk of cognitive decline and progression of Alzheimer's disease. Today, she'll be presenting on the characterization of the earliest cognitive changes in preclinical Alzheimer's disease with subjective cognitive concerns and information on digital tools for detection. Welcome, Dr. Robinson.
Thank you so much for the lovely introduction and for inviting me to speak at this seminar series. I'm very excited to have joined the department as faculty and excited to give this first talk summarizing some of my research. I'll go ahead and share my screen. And hopefully you guys can see the correct screen here, yes?
Yes, looks great.
Thanks. So yes, I'm so happy to be here to share a little bit of the work that I've been doing the past few years on characterizing earliest cognitive change in preclinical AD. And I'll focus, like was already mentioned, on some of the work that I've done looking at subjective cognitive decline and digital assessment tools. I have nothing to disclose for this talk. So my bio already kind of explained this, but just to talk a little bit about my background, I got my degree in psychology at the University of Miami and biology at the University of Miami, and completed my PhD in clinical psychology at the University of Georgia. And I did all my clinical training across multiple sites in Atlanta, primarily focused on neuropsychological assessment across all variety of neurological diseases, but I've really had an interest in aging and dementia, and that was kind of the focus of my clinical training on internship and certainly on fellowship here at the Harvard Partners Consortium in Neuropsychology. And I was specifically involved in the aging and dementia track, which actually allowed me to commit much of my time on fellowship to doing research, both using clinical trial data from the ongoing clinical trials at the Brigham, as well as using data from the Harvard Aging Brain Study, which is a longitudinal study of cognitive aging in a cohort of what was initially cognitively normal older adults who have been followed up to 13, 14 years now, including longitudinal neuropsychological assessment, structural MRI, amyloid PET, and we've introduced some digital cognitive tools in the last several years. So some of the data I'll be using will, some of the topics I'll be talking about will be presenting on data from the Harvard Aging Brain Study. So I'm sure this is probably preaching to the choir, describing what Alzheimer's disease is. Just to clarify also kind of from the neuropsychological perspective, some of the things that I do clinically when working with Alzheimer's disease and dementia. So dementia being this kind of umbrella term to describe decline in mental ability that impacts or disrupts daily functioning, can consider a number of cognitive domains and processes that can be affected due to any number of pathologies or disease processes that can lead to dementia, with Alzheimer's disease being the most common neurodegenerative condition that leads to dementia. It's characterized by, well, thought to be characterized by kind of regional volume loss in the hippocampus or mesial temporal lobes, impacting temporal limbic pathways that is also associated with primary deficits in memory, or at least in typical Alzheimer's disease, deficits in memory and semantic access, which then progress kind of globally to include multiple domains and lead to functional impairment. And we know recently the NIA and Alzheimer's Association have developed their research criteria that really define Alzheimer's disease by its biological features, particularly the presence of amyloid beta and tau plaques, and I'm sorry, amyloid plaques and tau tangles. And the clinical designations, so things like mild cognitive impairment or a mild neurocognitive disorder, major neurocognitive disorder, are really based on kind of the clinical features. Although this NIA framework that really focuses on these A, T, and N processes, so amyloid accumulation, tau accumulation, and neurodegeneration, although there is some discussion about using these biological definitions to classify this disease, what I'll talk about is the benefit of that will allow us to identify those who might be showing signs or developing this AD pathology before they progress to this clinical dementia state and possibly target that population for disease-modifying therapies. So we know that amyloid deposition, which really begins kind of in the temporal basal and frontal media areas and progresses, tau pathology, which is thought to begin focally in the entorhinal cortex, and then in the presence of amyloid expands pathologically to the inferior temporal cortex and other cortical regions. And neurodegeneration, of course, we know the mesial temporal lobes are particularly involved, which then progress to more global cortical atrophy. And all this is thought to be associated with the clinical features that we see, or the cognitive changes that we see tend to be associated with these biological processes. So specifically, we see memory storage impairments. So this kind of classic profile of Alzheimer's disease is really thought to be this primary amnestic syndrome associated with mesial temporal sclerosis, not sclerosis, but hippocampal involvement. I'm getting mixed up with my epilepsy patients. I apologize. As well as tau pathology, which accumulates there in the entorhinal cortex and inferior temporal cortex. But I also want to distinguish what we see clinically in Alzheimer's disease from other types of disease processes that impact memory. So when we think about a neuropsychological profile of memory performance, Alzheimer's disease is pretty normally classified as this amnestic profile where memory storage is really impaired. So the ability to hold on to information over time, as opposed to what we might see in other memory profiles associated with more frontal subcortical dysfunctioning. So encoding deficits, so deficits getting information in, retrieval deficits. So those tend to be associated with other disease processes where that memory storage and amnestic profile is what we tend to look for in that kind of classic cognitive profile in Alzheimer's disease. We also see involvement of semantic networks. So again, thinking about temporal limbic dysfunction that impacts things like confrontation naming, semantic fluency. And as the disease progresses, of course, we see dysfunction in other areas. So executive functioning, attention and working memory towards the later stages in visuospatial and language functioning that really starts to contribute to this breakdown of functional ability and lead to dependence. And when we measure cognition, we can use both domain-specific measures, so kind of longer batteries of multi-domain neuropsychological measures, which you might see in a typical neuropsychological evaluation, that really help us understand the cognitive profile of a person. So being able to test all these different domains, we can try to parse apart, does this person really have this, kind of primary temporal limbic dysfunction where we see memory storage deficits and semantic access deficits that might distinguish them from another pathology. And then we also have more global measures that are used for kind of characterizing the overall severity of cognitive impairment, as well as kind of tracking the severity or the progression of cognitive impairment over time. So things like the clinical dementia rating scale, these are commonly used as outcome measures for clinical trials to really track progression, or in the cases of our disease-modifying therapies, hopefully seeing a slowing in progression of the rating or the overall severity of cognitive impairment. So in considering this clinical pathological, profile, here we go. I think my slides are a little delayed, but hopefully we can manage this. So I'm sure many people have seen some version of this graph before, but this is really kind of describing what I alluded to before, or visualizing what I alluded to before, that by defining Alzheimer's disease by its biological components, although there are some, discussed drawbacks of that. One thing that it does allow us to do is identify those people who might be at risk of developing or at risk of progressing to AD dementia based on identifying the accumulation of amyloid and tau before they start to demonstrate clinical impairment. So before they start to demonstrate cognitive impairment on our neuropsychological measures. And this is what we now describe as kind of preclinical Alzheimer's disease. So people who have positive biomarkers, but are not yet at the stage where they are MCI, where they have memory impairment. And so if we focus on this group of people, as has been done in these clinical trials, and we focus on reducing their biomarker burden, can we prevent the progression of the disease? And so really the research that I've done and the populations that I work with are in this, what we call preclinical stage. So individuals who are cognitively normal based on their performance on our neuropsychological measures, but are defined as at risk based on presence of amyloid. And so these, so the goal of some of the research that we're doing is really detecting and intervening at this stage, which hopefully will be very promising. And another thing to consider about Alzheimer's disease is really the disparities in risk of dementia. So it's pretty well established that there are disparities in risk of dementia, disparities in brain health, cognitive aging, where we see that Black and African American older adults are at greater risk of developing clinical AD relative to their non-Hispanic counterparts or non-Hispanic white counterparts. They stand at about 2 times the risk, where Hispanic older adults stand at about 1.5 the risk. And there's a lot of considerations for why these disparities might exist. So one common hypothesis is the contribution of other pathologies, specifically cerebrovascular disease. So we know that cardiovascular disease is known to be a modifiable risk factor for Alzheimer's disease. And we also know that historically, disparities in cardiovascular risk and disease have also tended to fall around or along ethno-racial lines. So it could be that greater risk or greater kind of lifetime burden of cardiovascular disease and cerebrovascular disease might put individuals from certain ethno-racial groups at greater risk. And then there's also other psychosocial factors to consider. So other health disparities, differences in access to brain health promoting lifestyle practices. We can think about cognitive reserve and things that promote cognitive reserve, particularly higher educational attainment, higher occupational intensity. Those are also things that have historically fallen along racial lines in our country that might also contribute to this difference in risk. However, another important consideration is recent findings of differential biomarker burden across ethno-racial groups. So there is clinical trial evidence, and I put an asterisk next to clinical trial because I think that's important. So clinical trials are not necessarily always representative of the greater population. They're highly selected samples. And so that is an important observation to make. But clinical trial evidence does show that there tends to be lower biomarker burden, particularly amyloid burden, among non-Hispanic Black participants in AD clinical trials. And some work that has been published by my friend and colleague, Casey Dieters, in looking at the A4 study. So this is the anti-amyloid and asymptomatic Alzheimer's disease study that recruits cognitively normal older adults for participation in a randomized placebo-controlled trial of an anti-amyloid therapy. Participants in this study who had greater degree of African ancestry actually had a lower risk of both cognitive impairment and amyloid burden associated with ApoE4 carriership. So again, there might be differences in this biomarker burden that are conferred or differential risk conferred by some things that we commonly associate with increased risk of AD across ethno-racial groups. Another, of course, important consideration is underrepresentation of these groups in clinical trials. So I think it's fairly well known that underrepresented groups, Black, African American, Hispanic, are not well represented in a lot of our AD clinical trials, particularly those that include things like amyloid PET or postmortem pathology. And so those might contribute to kind of sample biases. So perhaps these differences are really just due to the fact that we're not getting as representative sample of these ethno-racial groups. And also there's important considerations to make about how we measure cognition. So also in this study, Dr. Dieters found that at screening, Black and Hispanic participants for the A4 trial were much more likely than their non-Hispanic white counterparts to be screened out of the trial, so they didn't get to the amyloid PET part of enrollment because of their performance on cognitive measures. So they're more likely to be screened out. And we also know that using cognitive measures as that screening tool, knowing that many of our cognitive measures don't have really well representative normative samples, could be another reason why we see some of these, at least differences in both performance on cognition and enrollment in our clinical trials. So putting that into context, this is just important to recognize how that might contribute to some of the differences that we see. So I want to switch gears a little to talk about subjective cognitive declines. Given that we're dealing with the disease process where amyloid and tau accumulation precede the clinical syndrome, we should really consider what other potentially more subtle indicators of cognitive change we might be able to use to either associate with biomarkers and increase our ability to predict who is at risk or who may go on to experience this pathological and functional decline. So we can turn to SCD as a potential early indicator of this subtle cognitive change. And subjective cognitive decline is defined as the self-experience of decline in cognition in the setting of normal performance on standardized cognitive tests. So they go get a neuropsych assessment, it's considered clean, everything is within normal limits, but the person is reporting, I'm experiencing some changes in what I believe is from my baseline, usually not significantly impacting their day-to-day life, but it's a notable change for them. And this also becomes really important. Just another little clinical note is that when we see people who are what we consider high cognitive reserve, we see a lot of patients, especially in the Boston area, with very highly educated, high occupational attainment. And these people, considering the strong association between performance on neuropsychological testing and things like education, usually perform really well. And this SCD, even the face of normal cognitive performance, is really the first indicator of change. And what we see in studies of subjective cognition, many of which have been conducted by my mentor, Rebecca Amarillo, who is also at the Brigham and works in the Harvard Aging Brain Study, is that SCD may in fact represent this earliest symptomatic manifestation of AD, and that we see significant associations between SCD and patterns of neurodegeneration seen in MCI and AD. So hippocampal volume loss. We also see greater amyloid and tau burden associated with SCD, and these are among samples of cognitively normal older adults. And subjective memory concerns specifically tend to be associated with amyloid in a way that is not typically found with objective cognitive measures in these cognitively normal samples. We also think, or I also think, that it could be important considering that objective cognitive measures, or some of our objective cognitive measures, do tend to show that African American and Hispanic older adults perform worse, even in the absence of any pathology. So it's possible that understanding the role of subjective cognitive decline as a potential indicator of early change across ethno-racial groups could also be really important in identifying those who are at early risk of further, objective cognitive impairment. So we want to really understand the association between subjective cognition and objective performance. So is people's experience of subjective change reflected in subtle changes in their objective performance, even if it's within that normal range? And there have been differences kind of in the literature. Some people do find significant associations between objective cognition, others don't. And there is also a pretty well-known influence of psychosocial factors. So greater depression and anxiety tends to be associated with SCD, and that kind of makes sense, but it may contribute to people's subjective experience of their cognition. So we wanted to really understand how subjective cognition is associated with objective performance and biomarker burden across ethno-racial groups. So we looked at SCD within the baseline data from the A4 study. Again, so this is the screening data, or the baseline data from the A4 study. They're recruited as cognitively normal. At the screening stage, these people are both amyloid positive and negative. So this is before they're actually enrolled in the study and receive and are designated to a treatment group or not. But at baseline, we have these 4 ethno-racial groups. So we looked at the non-Hispanic Black, non-Hispanic white, Hispanic, and Asian samples. And we wanted to evaluate, like I said, the associations between objective cognition and amyloid. And looking here at this demographics table, you can see some pretty significant differences in sample size. As I mentioned, these non-Hispanic Black and Hispanic groups tend to be underrepresented. And so that is obviously a limitation of this study. But there's also some important differences to notice in some of our key variables of interest. So if you look at our measures of amyloid burden, you can see that the non-Hispanic Black and Asian samples already stand at a lower burden of amyloid relative to the non-Hispanic white group. So this is also reflective of what Dr. Dieter showed in her paper, also looking at this data, where we see that there's a lower burden of amyloid among the non-Hispanic Black group relative to others, but also here in the Asian sample. We also see it kind of expected what shows in previous literature, differences in cognitive performance. So here on the PAC, which is a fairly well-known cognitive composite score, the preclinical Alzheimer's cognitive composite score, which is used in many clinical trials as a composite measure of different domains of cognition. And you can see that the non-Hispanic Black group is performing low or relatively low, as well as the Hispanic group compared to the non-Hispanic white and Asian samples. So looking at, I also want to point out there were differences in our rating of subjective cognition. So our SCD measure here is a cognitive functioning index, which is a self-rated measure of subjective cognitive decline. So it looks at cognitive decline across different domains and change in the last year. And there are significant differences across our ethno-racial groups and how much they rated their SCD, with the Asian group rating the highest. Then when we look at our association with objective cognition, and we did this two ways. So we looked at a between group analysis where we have a kind of an interaction of race to really look at the association of subjective and objective cognition by ethno-racial group. And we also looked at within group analyses to really see within group, what does this association look like, kind of devoid of the comparison to race or across race. And in our between group analysis, we do see that overall there is the expected association between subjective cognition and objective cognition, such that higher ratings of subjective cognitive decline are associated with lower performance on the PAC, so lower performance on an objective measure. But there is a significant interaction of ethno-racial group such that the association between objective and subjective cognition is significantly weaker in the Hispanic group relative to the non-Hispanic white and Asian groups. And they weren't differences between the other three groups. So we do see some effect of race in this association. When we look at our within group analysis, we actually see that there is, again, this great association of greater self-reported SCD and lower objective performance, but this association was only significant in the non-Hispanic white and Asian samples, whereas the association was not found in the Hispanic and non-Hispanic Black samples. And notably, when we include, as these analyses, we control for age, sex, education, and we also included performance on a self-rated depression measure and self-rated anxiety measure. And we find that depression and anxiety ratings were significant predictors in the model of SCD only in the Hispanic and non-Hispanic Black groups and not in the non-Hispanic white and Asian groups. So it appears that depression and anxiety are contributing to the experience or the rating of subjective cognition more so than objective cognition in these ethno-racial groups. Here we can see the association of SCD and amyloid across our groups. And again, we see, as expected, greater self-reported CFI or greater subjective rating of cognitive change is associated with greater amyloid burden. And again, we see a significant interaction of ethno-racial group. So the association is weaker in the non-Hispanic Black group relative to the Asian sample. And in our within group analysis, we see a very similar pattern where greater SCD is associated with higher amyloid in the non-Hispanic white and Asian samples, but this association is not found in the non-Hispanic Black and Hispanic samples. So in this work, we also did some other analyses looking at things like study partner rated subjective cognition and if that differed by race, and we didn't really see differences there. But ultimately, what we're concluding is that while SCD does tend to be associated with objective cognition and amyloid, which suggests that it could be an early indicator of amyloid-associated cognitive change, it does appear to have a different, or this relationship appears to be different across racial groups, and we might need to better understand the contributions of these psychosocial factors to people's self-ratings of their cognition to better understand how, if SCD can really have some utility in predicting pathological change, actual pathological cognitive change across ethno-racial groups. I want to quickly switch now, if this isn't too abrupt of a change, to some of the work that we're doing with digital cognitive measures. So in the same way that subjective cognitive decline is also meant to detect these preclinical subtle indicators of cognitive change in that earliest stage of change where amyloid and tau might be kind of brewing, but more significant clinical change hasn't yet been detected. The goal of digital cognitive measures is to also help us understand more subtle indicators of cognitive change that our traditional paper and pencil measures may not collect. And with digital cognitive tools, we might be able to not just detect kind of primary outcome measures. So when you think about traditional neuropsych tests, getting just a time to completion on a task or how many words they remembered, a digital cognitive tool might really be able to detect more process scores. So things that are not typically captured in those global measures or in a single score, but things like decision making and processing speed, error frequency, and the types of errors. So here's a graph that is also included that typical trajectory of amyloid and tau burden and clinical change that we see in Alzheimer's disease and preclinical Alzheimer's disease, but it's also depicting that our standardized tests are really good at picking up when people are impaired. Once there is some impairment, once they've passed that detection threshold, our measures are fairly good at that. We're comparing them to a normative sample. But the digital measures that we're using might be able to detect change before this detection threshold. So really at the earliest stages. So that's where we're hoping these things will come in. So the digital PIN tool is one digital assessment measure that has been implemented in the Harvard Aging Brain Study, as well as some other, I believe it's also been employed in some other clinical trials, not as a primary outcome measure, but it's used as a PIN, really the same way that participants would complete paper and pencil measures. However, it has a camera mounted in it. And so the camera mounted in the PIN, along with a specific type of grid paper that is used to complete the tasks on, allows the PIN to collect timestamp coordinates of participants' kind of space on the page and calculate these or transfer these timestamp coordinates into more specific variables that might capture nuanced aspects of their performance. And so this digital PIN has been used on a digital clock drawing task. We also have it available for the trail making test. We have it available for a digit symbol substitution test. And I'll talk a little bit about the maze test, which I have been working with. But using the digital clock test, which has now been made commercially available, it was FDA approved for detection of cognitive change and differentiating between normal cognition and MCI. We're able to actually see this digital clock test, the DCT clock test summary score, in association with amyloid. And we see this association in this digital test score that is kind of stronger, or it's present where this association between PAC and amyloid was not present in a cognitively normal sample of older adults. So there's real hope that this measure might be getting at really early subtle changes that even these kind of gold standard cognitive composite scores that are designed for looking at preclinical cognitive change may not be able to detect. So I have been working with this digital maze tool using the digital PIN to look at a different test. So not the clock test, but a maze test that has a choice and a no choice condition to understand if performance on this digital maze test may also be able to differentiate early cognitive change associated with kind of preclinical Alzheimer's disease or biomarkers at the cognitively normal stage. So this digital task includes, like I said, a choice and a no choice condition. So here we have a maze in this no choice condition where participants are asked to complete the maze simply by following along the path until they get to the end. So this no choice maze doesn't include any decision making. However, at the choice maze condition, you can see here in the middle panel, we've subtracted some spaces of the wall where now, in order to complete the task, participants have to make decisions in order to get to the correct solution path. So for this task, participants are asked to complete the maze as quickly as they can without lifting their pen. If they make a mistake or come to a dead end, they're asked to backtrack and, of course, don't penetrate any walls or don't cross any walls the way you might complete a regular maze. But in a traditional maze test, we might only get something like time to completion of this test, whereas our digital tool is able to collect more variables, which I'll talk about some of the cooler variables that we have in a little bit. But our initial pass of this task, we had some very core features. So the total time to complete the test, which is a traditional, kind of outcome measure from such a task. We had a total ink time, so the amount of time the pen was actually on the page. We had a pin off page time, so how much time was spent by each participant with their pin off the page, hopefully thinking that that might indicate some degree of greater difficulty that they had to lift their pen, and also how many strokes it takes them to complete the maze. Again, the hypothesis would be the more strokes, the more times you lift their pin, that would be an indicator of greater difficulty with the task. And so for this digital maze test, we're looking again within the Harvard Aging Brain Study. So we have a subset of participants who received this tool. It was introduced later in the study. Of course, the study has been going on for many years. And we wanted to evaluate the performance on this digital maze test against traditional measures of executive functioning and processing speed, as well as memory, and evaluate its associations to amyloid and tau biomarkers. So here we have our sample of 172 adults from the Harvard Aging Brain Study. Just typical of our participants in the Harvard Aging Brain Study, they tend to be mostly white and pretty highly educated, so average about 16 years of education. And this is a mostly cognitively normal sample, although by this point of the Harvard Aging Brain Study, we do have some people who have progressed to MCI and dementia. And just to inform you that all the analyses we conducted were conducted in the total sample as well as the cognitively normal only sample, just to verify the associations that we saw. And we have a mostly amyloid negative sample here. So we're using Pittsburgh compound B to quantify cortical amyloid burden. So first, I'm just showing a pretty big and hopefully not too messy correlation matrix looking at some of our composite scores. So we created a composite score of those maze features that I showed you earlier for the choice condition and the no choice condition. And we can see down here, looking at some of our traditional paper and pencil cognitive domain scores, we see that the digital maze test does have a moderate correlation with things like executive functioning and processing speed in the expected direction, less so to memory, which is fairly somewhat expected given that this is not a memory test, and does so again, modest correlation to the PAC, which is our kind of traditional cognitive composite outcome measure. And looking at amyloid and tau, we see that there is a weak but significant association to amyloid burden and no association we see to tau. And you can talk a little bit about that later, the consideration that tau is really something that's largely associated with memory performance, and also tau is typically thought to be associated with cognition at later stages. And so it's possible that in this mostly cognitively normal sample that is thought to be, kind of preclinical Alzheimer's disease, we might not expect to see significant associations with tau and an executive functioning measure. So we did look at the associations of our composite scores and cortical amyloid burden, and we see that worse performance in our maze composite was significantly associated with higher amyloid burden. And kind of not direct comparison, but for reference, I would say, I listed some associations between amyloid burden and our traditional paper and pencil measures. So kind of similar pattern of association between trail making test B and cortical amyloid. But in terms of more other, or I guess more traditional processing speed and working memory tests like trail making test A and the digit symbol subtest, we don't see associations between cortical amyloid and these measures. So it's possible that our digital maze test is picking up on some subtle amyloid-associated changes that our other measures do not. We didn't see any associations between tau in our regression models here, as I mentioned before. Another way that we looked at this data was looking at a partial least squares regression analysis of amyloid and our maze variables individually, to see which maze variables are really contributing to this association that we see with amyloid. And here we see that higher PIB is overall in our kind of univariate analysis associated with amyloid, but the weights of the individual variables that appeared to be most relevant for this association were things like pin-off page time and higher number of strokes. And so I think it's important that we to point out that these are measures that might not be captured in a traditional maze test by just timing how long it takes someone to complete it, but these are variables that are really uniquely captured by the pen that appear to be most relevant for this association with cortical amyloid. On this next panel, this is maybe not super statistically sound, but kind of an exploratory fashion, considering that we didn't see an association in our univariate analysis with flortaucipir or our inferiotemporal and entorhinal cortex tau. We were really kind of just trying to explore what variables might be related, but these, I would put a kind of an asterisk on these results here because there's no univariate association. However, in our tau associations, we do see that things like pin-off page time and higher number of strokes are associated with tau accumulation in the entorhinal cortex, parahippocampus, and hippocampus in these partially squared regression analyses. And then more recently, because we've been working in this collaboration with these digital pin variables, we've actually, with this digital pin tool, I'm sorry, we've actually gotten more variables that the pin is able to detect. And so here I have listed on the left additional variables beyond the ones that I've already mentioned that might even further kind of characterize really nuanced performance on this test, including backtracking count, how much time was spent in the path that deviates from the solution path, many speed variables, so max speed, minimum speed, average speed, variability or in speed or speed standard deviation, wall penetration count. So here we have a lot more variables that might speak to errors on the task and variability or hesitancy in performing the task. And this was really interesting to us because one hypothesis that we had that was introduced by one of the neuropsychologists who we've been working with in executing this task for the Harvard Aging Brain Study is that clinically, when using this test, she finds that cognitively normal people tend to approach a maze by having a much more kind of consistent speed as they complete the task. They start off relatively measured in their speed. As they approach a choice, they're able to maybe anticipate the choice and look ahead to determine which choice might be most appropriate and proceed in a much more consistent fashion throughout the test, where someone who is more cognitively impaired might kind of be fast out of the gate, very fast on long paths in the maze, and then once they reach a decision point, slow down or stop drastically before making that decision and proceeding through. So they have much more variability in their speed as they approach the task. So working with a data analyst in our group, this is Grace Del Carmen, who did some of this work and has presented it at some conferences recently, including the Alzheimer's Association. So we were looking at these newer variables, and we found that the wall penetration count, so errors in performance on the maze, as well as the standard deviation of speed, so again, speaking to that speed variability, were associated again with amyloid burden in this mostly cognitively normal sample.
Excuse me. Sorry, can I ask one question in between?
Sorry, yes.
Is that okay? I saw a similar presentation on kind of like speed and accuracy, where they were also looking at gender sex differences, where the stereotype was a bit confirmed that men tended to be faster but made more mistakes, versus women were slower and more accurate. And I was just wondering, is this something that kind of comes out in your analysis as well? Sorry for interrupting, but it was specific to this one.
No, we haven't looked by, we can usually control, goodness gracious. We control for sex in our analyses. Just in most neurocognitive measures, we usually control for sex, especially with anything that involves a visual spatial outcome, because there do tend to be differences by gender based on in visual spatial ability based on gender. But for these analyses, we hadn't broken it up specifically to look at sex or the differences in performance across men and women. But that is a very interesting finding. And I wonder if we would see a similar pattern in speed variability based on the observation that you point out. But that is certainly something that we can look into. No insult to the men here, but that is kind of an interesting and entertaining observation. So another way that we looked at this data was really looking at a principal component analysis to try to understand if there are certain patterns of performance on the maze that are associated with greater amyloid burden. And so here we were really interested in the first two principal components that came out of this analysis that explained greater than 15% of the variance here and all the variables that were included. And in those first two components, what we found is this component one that was largely associated with slower speed and longer completion time. So I've included here all the variables that represent greater or less than positive or -1 in their weights for our PCA. And all of these measures, as you can see, are associated with time and speed. So greater time duration, longer total ink time, and then slower speed. And this accounted for the most variance in our principal component analysis, but it was not actually associated with amyloid, but really age accounted for a significant variance in our model when we looked at the profile of this maze performance with amyloid burden. The second component I thought was pretty interesting. So this accounted for about 15% of the variance in our model. And all the measures that are included in this component are associated with, it's kind of like a double negative, so I'm going to try to say this right. But it's characterized by things like greater potential planning time and lower error time. So the variables that are included in this model tend to be lower things or lower time spent deviating from the solution path, less time backtracking from where they were when they make an error, as well as greater time in the start cells, which we were a little surprised by, as one might think that spending greater time in the start cells might be indicative of greater difficulty. Maybe it's taking you too long to get started. That's suggestive of some hesitancy. But considering that this profile was actually associated with less amyloid burden, we actually hypothesized that this might be capturing some planning time. So people perhaps spending greater time in their start cells, planning out their maze, visualizing the path before they get started, and spending less time deviating from the solution path and backtracking was actually associated with less amyloid burden. So conclusions for our kind of digital maze tests, we're finding that their maze performance is moderately associated with traditional executive functioning and processing measures, less so to memory, which might be expected based on the nature of the task. We find that performance on our maze, particularly no choice maze, was actually associated with greater amyloid burden, but less so with tau. And I mentioned before, considering that this is a non-memory test and a mostly cognitively normal sample, it might be this association we see with amyloid, but not with tau, is indicating these subtle changes are associated with the earlier clinical or earlier cognitive changes in this preclinical trajectory, but not yet capturing some of the downstream effects or later effects of tau that might be more associated to more significant memory impairment. So overall, we find that these digitally captured nuanced performance measures might be related to early biomarker burden, but of course, we will want to follow up with some longitudinal analyses to see the utility of this test to predict cognitive change or predict changes in amyloid and tau. And that's kind of what we're working on now with this measure, and hope to be submitting to some conferences coming up. And I will wrap up just by talking about some other work that I am doing and planning to do. So I mentioned before, one consideration about our framework when we're thinking about the pathology that contributes to Alzheimer's disease, as well as potential differences in the pathological contributions to cognitive change that might explain some of the differences we see in brain health outcomes across race. I've become really interested in understanding the role of cardiovascular risk and cerebrovascular disease in cognitive trajectories. So the primary pathway of AD is really thought to be the accumulation of amyloid beta, which leads to the pathological spread of tau and then eventually cognitive and functional impairment. But there's kind of well-established evidence now of the contributions of cardiovascular risk, cerebrovascular disease as a significant component of the AD pathological process. And so there are shared risk factors between Alzheimer's disease and cardiovascular disease. There's recent research, including from our group, using Harvard Aging Brain Study as a sample that show an interactive effect of cardiovascular risk and amyloid beta on cognitive outcomes, and the idea that this synergistic relationship between cardiovascular disease and amyloid might lead to a greater accumulation of tau that leads to more severe, more rapid cognitive impairment. And so it's important to recognize that some of the clinical trials that we have available to evaluate this actually exclude higher degrees or higher burden of cardiovascular disease. And so it might be that we're not really able to adequately capture the impact of cerebrovascular disease on cognitive outcomes. And so I really think there's an opportunity to understand how this process is involved and also how this process might contribute to differences that we see, especially across ethno-racial groups. And that's kind of the focus of some emerging work that I'm doing and planning to use the US Pointer study, which is a study that's adapted after the Finger study that is actually evaluating more nutritional and lifestyle interventions for preventing Alzheimer's disease. And it's a really great sample because they have oversampled for underrepresented minority groups in the study. So I think they have 33% of their baseline sample from underrepresented groups. And they've also oversampled for individuals with cardiovascular disease. It's actually one of the inclusion criteria as having sedentary lifestyle, poor nutrition, or any number of cardiovascular risk factors for inclusion in the study. And so we hope to use this study possibly in parallel, looking at the Pointer study and the A4 study to try to understand how these samples may differ, try to characterize the associations between biomarkers and cognitive outcomes to see if we are able to replicate some of the traditional associations that we see with biomarkers and cognitive outcomes in this more racially diverse sample and kind of medically diverse sample, considering the greater burden of cardiovascular risk and disease. And we also hope in the Pointer study to look at more kind of novel indicators of cerebrovascular disease and how it might explain both differences in cognitive outcomes across racial groups and if it, has greater or less contribution to their outcomes considering this greater burden of cardiovascular disease. So I kind of mush-mouthed through that last bit, but that is kind of the future of some of my work. I still really hope to continue working with samples that are, representative of our larger older adult population to really characterize these preclinical Alzheimer's presentations for the wider, more diverse older adult population so that we can target our therapies and evolving disease-modifying treatments that will be equally effective and equally accessible across our older adult population. So with that being said, I think I'm all done. I tried to leave some time for questions, but thank you so much for your time. Again, thank you for inviting me. Yeah, really appreciate the opportunity.
Okay, thank you, Dr. Robinson, for that wonderful presentation. Very interesting. We have one question in the chat related to the digital tools. Are you able to see the chat?
Yeah, I think yes, I can pull it up here.
There's a question there about differentiating between functional cognitive impairment using these tools versus SCD as preclinical MCI AD path. I think Zaina's on the call. Maybe she could clarify.
Gene, maybe we could take the slides down.
Oh, yeah.
I'm sorry?
It's good.
Hi.
Hi, Zaina.
Hi, Dr. Robinson. Thank you for your talk. We are seeing more and more of the functional cognitive impairment, and especially in a white population that is well-educated post-pandemic. So I'm wondering, And often, I mean, in the pen and pencil, we ask for the Tom test and other stuff, but I wonder if the digital test, because you said that they could be a bit more sensitive, would actually just tell us which is which. So that was my question.
Yeah, that's a really interesting question. I don't think I've ever seen or heard of anyone using digital tools in the assessment of functional cognitive disorder, but I imagine it could be quite difficult. I mean, if we're looking at really subtle cognitive changes, one suspicion, especially for functional cognitive disorder, at least one suspicion that I have clinically, is that individuals who, you mentioned post-pandemic, who might have some subtle cognitive changes after a mild COVID infection that maybe has, I guess, devolved, so we say, into a kind of more functional presentation, is that there possibly is maybe some very subtle processing speed or attentional changes that have manifested that are maybe the experience for that person is that there's greater impairment, and it end up manifesting as this more functionally impairing what they're reporting, like these greater difficulty in cognitive domains that are impacting their functioning, and that a digital assessment that really picks up on nuanced subtle changes might be able to show, yeah, like, there are some subtle changes in your processing speed, or there's some subtle inefficiencies in your executive functioning. And maybe that could be, I don't know about differentiating that between, yeah, I guess I don't know how fruitful that would be in terms of differentiating, because I feel like maybe those subtle impairments might be revealed on a digital assessment tool where they wouldn't be in a traditional paper and pencil measure that might suggest, yeah, you do have some subtle cognitive changes. They may not be, I don't know if that it would, I feel like I'm stumbling over my words because I don't want to say the incorrect thing, but it may not be helpful for, might be helpful for ruling out other causes of that cognitive impairment or of that subtle cognitive change, because those could be changes due to a subtle COVID infection that are just, our measures are really not equipped to pick up on that. But it doesn't necessarily, I think it might be hard to use that in the form of differentiating different reasons for why they might have subtle attentional or processing speed changes. I'm not sure if that answers your question.
Thank you.
It's okay. We also have a question from Nanda. It's raised hand. Go ahead, Nanda. Are you there? Let's see. Well, while we're waiting for Nanda to come back here, so I had a question about ApoE4 genotype and whether or not you've looked at genetic risk factors for Alzheimer's disease and how these influence some of these preclinical measures. So for example, the digital pen test is very interesting. So I had one question about that, the interaction with genetic risk, but also whether or not the digital pen test has been used in clinical trials to see if it's modifiable, and from an interventional standpoint. Thanks.
Yeah, those are great questions. So I haven't looked in our data looking at the interaction based on carrier status, but I think that would be an excellent thing to pursue and look at with our data. In terms of clinical trials, I do know that the digital pen has been used or has been included as part of the cognitive assessment battery in multiple clinical trials. As far as I know, not too much of it has been reported on, especially on kind of the longitudinal data. So these are things that people are kind of just diving into. So we do have the digital pen tool that is available in the Pointer study. So I'm hoping to include those digital assessment measures in my work looking at cognitive outcomes associated with the AT, N, and V variable. So I imagine that's pending, but they have included them in clinical trials. I think the hope is that it will, if we can really show that they are useful in detecting cognitive change and they show some reasonable association to biomarkers in the expected way, that it will be a much more time saving way of assessing cognition as opposed to these longer batteries. So they are being included, but at this point, they're not considered primary outcome measures for cognition.
Thank you. We have a question, Dr. Tanzi.
Great talk. Really enjoyed it. I think this digital maze has so much potential. So congratulations on developing that. I'm wondering if you've considered the digital maze and whether it might be a more enhanced result if you use virtual reality together with it. I ask this because I'm involved with a company I started with Brian Nahad, Sean Patel some years ago, called React Neuro, where we're using virtual reality neuropsych exams plus eye scanning and voice analysis to assess brain health and diagnose disease. And we find that the virtual reality trail making test seems to be much more effective than just a paper 2D test. So have you considered any virtual reality applications?
Yeah, so we don't have virtual reality for this test yet. I will say we work in collaboration with a computer scientist from MIT named Randall Davis and a neuropsychologist from Leahy named Dana Pinney. And so in collaboration with them, they've developed this maze test with the pen. So I can't take all the credit, but they have been working on ways to improve it. So the digital pen version of this was kind of the first version of this. And one thing that we're really interested in, especially when we think about things like are people anticipating their next step as opposed to just solving the maze kind of step by step, is eye tracking. So associating eye tracking with their digital maze performance. And so they have developed an iPad version of the test that includes some eye tracking. So not full virtual reality yet, but there are some other ways they're considering kind of.
If you're interested down the line of applying a virtual reality aspect to this with eye scanning, let me know, because we have a platform that's already being used in senior living and with the Patriots and different sports teams for assessing brain health, baselining, concussion. So it's kind of, it could be plug and play. Let me know offline if you're interested.
Yeah, we can certainly chat more about that. I think the digital pen will be kind of left in the dust pretty soon, considering that we have these newer versions of it that have much more technologically advanced ways of capturing some of these aspects of performance.
Thanks.
Okay, thank you. We have another hand up. Dimitri, you have a question?
Yeah. First of all, thank you very much for this wonderful presentation. And I was wondering, so you mentioned also about early detection and using those digital tools for early detection. Have you looked into multiple time points and at the rate of cognitive decline? I was wondering whether those tools might be, or like what's their sensitivity in terms of detecting the rate rather than just some early symptoms.
Yeah, that's a great question. So the digital clock test is a little bit more advanced than we are in terms of the longitudinal analyses. So we've kind of just started working with the digital maze test and started with the baseline data, but we do have digital maze data on follow-up multiple time points for participants in the Harvard Aging Brain Study, and we're working to finalize those analyses to present soon. But the digital clock test actually does have some published data that presents on longitudinal amyloid and longitudinal tau. And we do see some sensitivity for the digital clock test to predict digital tau. So there's an instructor at the Martino Center named Jessie Fu, who has really championed that work. And she's submitting a paper, she's submitting this paper that's looking at longitudinal performance on the clock and biomarkers. And there is some sensitivity for detecting change in biomarkers. Yeah, so it's promising, and we'll see if the maze has a similar, performs similarly.
Okay, I don't see any other questions. Dr. Robinson, thank you so much for taking time to be with us today. Early detection, preclinical Alzheimer's disease is really the wave of the future, I think, and it's a major focus of the McCance Center. So thank you for coming, introducing yourself, and sharing your research program. Thank you very much.
Thank you again so much.
See you around campus.
Thanks. See you guys around.
Thank you, everybody, for attending.